How does facial fat grafting, also known as facial fat transfer, actually works? Hi, I'm Dr. Delaney, board certified facial plastic surgeon, and I'm going to show you with a few illustrations that I put together. First, the fat is harvested from the patient's own body, processed, and then injected back into the desired treatment area using a blunt cannula, as shown here. Next, the cannula is introduced into the area that we want to add the fat to, and then we deposit little droplets of fat as we withdraw. So this is really crucial because it is a free graft, the fat that's being transferred, so it needs to establish new blood supply. So it's really important how it's prepared and how it's injected. In order to maximize contact of the transferred fat with the surrounding areas, it's important that only small aliquots are injected to maximize the surface area at which it comes into contact with blood vessels. Now, it's also important to inject on withdrawal. This way, at the temporary tunnel that's created by the cannula collapses as we remove the cannula, and then so the fat is nicely trapped into the tissue plane, so it's not going to float around, it's not going to migrate the way sometimes filler may. And so this is repeated, and we inject in multiple layers to create a nice even distribution of fat. And so this is what the end result of fat grafting should look like. Sometimes depending on the areas, where there's thinner skin or thicker skin, we may change the distribution of the fat in terms of how deep or how superficial we put it. But the general idea is we want to spread the fat out to maximize the fat graft take rate. So what happens to the fat droplets once it's been injected? Now this illustration here shows three possibilities, and it really depends on the size of the droplet and how close it is to blood supply. So if you have a really big droplet, in the center of the droplet of fat is not going to be able to get enough blood supply, and so all that fat will end up dying and then will eventually be reabsorbed by the body. So that's why with fat grafting, I'll always tell patients you're probably not going to get 100% take rate, but depending on the quality of fat, the health of the patient, the health of the recipient site, and how the fat is prepared and injected, you can significantly impact the amount of take rate. Now, just outside of the necrotic zone is the regenerative zone. So this is the zone where the distance is just far enough from the edge of the droplet where the fat cells aren't getting enough blood supply and they pass away, but there are stem cells within the fat tissue itself that have enough blood supply because they don't need as much, and they're able to stimulate a regenerative change. So what patients may see is after initial swelling of their fat grafting has gone down, they may get a secondary little bit of a boost. And this is coming from the regenerative changes stimulated by these stem cells in the regenerative zone of the droplet. And then lastly, on the outside, on the periphery of the droplet, this is where the fat cells come into closest contact with the surrounding blood vessels. And this is where most of the fat cells have a higher chance to survive. So it's important that when we're injecting the fat, we want to try to keep the droplet as small as possible so that necrosis zone is as small as possible, which then directly has an impact on the fat transfer take rate.